What if I told you that by the time most people are diagnosed with type 2 diabetes, they've already lost more than half of the insulin-producing cells in their pancreas, and they had no idea? In today's episode, we're diving into the silent storm that unfolds long before blood sugar levels ever hit the danger zone. We're talking about pancreatic beta cell dysfunction, the primary and most overlooked defect in type 2 diabetes. We're going to learn what pancreatic beta cells actually do and why they're the unsung heroes of glucose control, how chronic insulin resistance can wear them down, forcing them to work overtime until they begin to fail, the critical moment when beta cell mass drops to 50% and why that's a major turning point on the road to diabetes, and what medications can slow this decline, and which lifestyle tools can protect, support, or even partially restore these vital cells. And finally, we'll tackle one of the most debated questions in diabetes care. Can beta cells ever regenerate? And does the answer differ between type 1 and type 2 diabetes? If you've ever wondered what's really going wrong at the cellular level, or how you can protect your body from the inside out, this is the episode for you. Let's get started. Hello, I'm Richie.
And I'm Amber.
And today, changing it up, we're getting right into it. We're talking about beta cell dysfunction. Ladies and gents, I'm going to clue you in. This is not going to be an easy episode. This is going to be some hard truths we're going to hear today. But hopefully, it's going to be some stuff that's going to motivate people to make some changes to get healthy. So, Amber, in last week's episode, we talked a little bit about the beta cells and the alpha cells in the pancreas and a little bit about what they do. Mm-hmm. And at the end of it, I made a guess that beta cell dysfunction is something that we might experience towards the end of the diabetes cycle. And you hinted that that was not the case and didn't give me any additional information all week long. And I've been on pins and needles. What's going on with the beta cells?
What's going on with the beta cells? Well, I think you bring up such a great point that most people think that the crap hits the fan, the proverbial, stuff hits when they're diagnosed with having type 2 diabetes, and they ask their doctor then, don't put me on meds, give me more time, let me do this first. And that's all well and good, but the reality is that damage starts years and sometimes even decades prior to that moment in the doctor's office. And when somebody is told that they have type 2, or when they're called by the medical assistant and told that their labs came back abnormal. So sometimes not even in the presence of their physician where they can ask really good questions. And so by the time you have diabetes, you've often already lost more than 50 to 85% of beta cell function.
Whoa. Say that one more time.
You want me to repeat that?
Yes, please.
Okay. How much of what?
What I heard was when I'm having the conversation with my doctor, mm-hmm. I've already passed a threshold. I'm getting put on medication because I'm in this pre-diabetes or diabetes bucket. I'm already at 50 to 85% depletion of beta cells, which again, these are the cells that are capable of producing insulin in my body.
Yes, the only cells that make insulin in your body.
Okay.
And that's exactly why blood sugar control becomes so difficult, because these cells are already exhausted and the body has exhausted so many resources trying to overcompensate. Our bodies are beautifully, wonderfully made, and we're going to try to have normal glucose levels. And the body's been doing other things to compensate for a really long time at this point.
So, is this like, for lack of a better description, are we just talking about like pancreatic burnout at this point in time? Is this mm-hmm. my pancreas has been, that pancreatic engine's been running at 8,000 RPMs for like 20 years, and it's not a Honda S2000 and was not designed to do that. And as a result, I've now got cracks in my head gasket, and I'm only getting like really 50 to 15% of the horsepower from my pancreas that I should be. Is that right?
It's a good little summary there.
Okay.
And that's why early intervention is so powerful and necessary, because the earlier you, listener, if you have type 2, the earlier you take action, the more we can do together to stop it, or you and your healthcare team can do together to stop it, or even reverse part of the damage.
So again, I before we go any further, really need to stress this. If I'm having the diabetes conversation with my physician, like, I'm already behind.
Yes.
Right? Like
Absolutely.
the start gun has already gone off.
And you're still in the block.
I'm just still in the block.
Yes.
Yeah. So I'm like, I gotta
with a parachute on.
for the people that have not had the conversation with the doctor yet, I think we've talked before about the fasting insulin test that we can do with when we get our regular blood tests. Like, is this the time to raise the, like, this should be standardized? Like, is this something, if I'm in my 30s or 40s, like, how urgent is it for me to get this test? Because again, I don't want to get to 50 to 15% function, like, it's
50 to 85% beta cell.
What I'm saying
loss,
is the leftover bit, right?
Right.
So if, again, this is, I'm sorry, I'm a little distressed. I'm going to take a couple of deep breaths here.
Okay. It's a distressing fact. Honestly, it's something that is not well talked about or well known.
Well, I mean, I'm to some degree flabbergasted, because to me, the fact that we allow this to get that far, right? To me, that there is,
and by we, you mean our healthcare system in the United States. I take
there's a lot of problems. The healthcare system that we have is definitely not, it is a reactive, not a proactive system. That's a whole different podcast. But I am feeling some degree of outrage that the time to take action to mandate doing something different is when, like, I like the letter grading system, right? To me, if I've got less than 70% function, you're not in the C category anymore. We're getting into a D. That's the time to have a parent-teacher conference, not when you're at a solid F. And by solid F, I mean a 50 to a 15. That's not okay. I can't bring that grade back. Or maybe I can bring that grade back. I don't know. Anyway, it's way too late. Talk to me when I've got a C minus, right?
Yeah.
Talk to me about my behaviors in the course that is health management, way before I've dug myself into an F that I can't dig myself out of. And I'm going to get off the soapbox now, but golly, this is a lot. This is a lot early. Usually we save this for later.
It is an alarm bell to be sounding, and I think that it is something that healthcare providers, myself included, people in this field, need to be shouting from the rooftops that this is something going on. And to speak to the fasting insulin levels, you can get that test done, and we've discussed that on a prior podcast, but that is something you can get looked at to see if there's something going on in the background. Another thing is if you're above your weight for height metrics, if you have excess body fat, overweight, obesity, that would be a cue that perhaps there's some insulin resistance there. So not everyone overweight or obese has insulin resistance, but many people who are insulin resistant are overweight or obese. And, the pancreas, which is that organ that sits behind your stomach, produces these pancreatic beta cells from the islets of Langerhans. Nothing anyone needs to know, but
That sounds like a good place to vacation to me.
it's no, maybe. But remember that insulin is the key that unlocks the door to the body cells. I've said this maybe every single podcast. I think we come back to this just to remember what insulin does, because the beta cells have one primary job, and that is to release insulin in response to rising blood glucose. So if the blood glucose levels stay elevated, these beta cells are just chronically overproducing insulin beyond their limit, and they can swell and strain and eventually burn out, as you were speaking to about the Honda. And it's not an overnight thing. It's very gradual, and by the time it shows up in an A1C in these levels that are diagnosable, you're at that 50 to 85% beta cell depletion.
Okay. So is there anything that we can do to preserve beta cell function? The limited amount of beta cell for function that I have, at or after diagnosis.
Mm-hmm. So I just want a quick reminder that it's the metabolic stress on the beta cell, either through insulin resistance but mostly it's exposure to excess glucose or excess fat. So we talked about lipodystrophy on a prior episode, and it's that fat buildup. And just like you can get fatty liver, you kind of get a more fatty pancreas as well. And then, of course, we've discussed certain pharmacologic agents, your TZDs like Actos, your GLP-1 receptor agonists like Ozempic, Bydureon, Mounjaro, things like that, semaglutide. And possibly even metformin can reduce the workload on the beta cells, which helps them function more efficiently and avoid burnout.
Is there a drug or a medication that specifically regenerates beta cells?
No, in type 1 diabetes, there's some really interesting stem cell research that's going on for repleting beta cell dysfunction. But the issue in that is that it's an autoimmune attack. So even though new beta cells can be formed, the body still attacks those new beta cells. But that is definitely an area in type 1 which is being developed. But as of now, beta cell repletion is really not available in type 1, but we're really sticking to type 2.
What it sounds to me like the medications that we're talking about are really working to maybe lessen the load on the pancreas, but not specifically helping to regenerate beta cells. It's specifically, there's less load because I'm more insulin sensitive,
right?
Which is great.
It's kind of just again, giving somebody, if you were a worker in a factory just doing back-breaking labor and somebody came in and you had a 15-minute lunch break, you get a little break, but it doesn't change the fact that you have back-breaking labor. So these medicines can help reduce some of the insulin resistance that's going on. But really the biggest lever that you can pull is lifestyle.
Okay. So what does that look like?
Well, your body, if you're exercising, exercise is really the biggest one. And if your body needs less insulin to get the job done, because again, skeletal muscle can soak up the majority of those post-meal blood sugar, that glucose in the bloodstream from that meal, that really takes pressure off the beta cells. And from a nutrition approach, creating a caloric deficit, meaning you're eating less calories than what your body needs on a day-to-day basis, and you're expending more energy than you're taking in. And what can help with that would be a very fiber-rich, low glycemic eating pattern. When you're getting high fiber foods, if you're getting whole grains and you're limiting your more processed, ultra processed foods, that is usually going to be a lower glycemic effect.
I know that you don't like to be prescriptive. I'm going to twist your arm again, and I'm going to ask you to define high fiber. I need to know thresholds. I need to know, like, again, I'm sorry. This is all pretty alarming to me. Like, I'm going to talk to my physician. I'm sending her an email after this thing. I better have my fasting insulin tested. What is high fiber to you?
The U.S. dietary guidelines, which I find so interesting with so many people, just a certain climate that's going on right now, talking about how the U.S. dietary guidelines don't work. People don't follow the guidelines. The recommendation is 25 to 35 grams of fiber a day. And taking that for,
That's for general population, though.
Correct.
Right?
That's for, as the cool kids say, Gen Pop.
That's great.
Yep.
I want to know, for our people, how much fiber do they need to be getting in their diet?
I would say a minimum of 35 grams. If you can get up to 50, that would, in my opinion, even be better. A lot of studies on cholesterol and heart disease have been done in somewhere between 25 to 50 grams of fiber. If you go into like colon cancer data, that's even, if you were able to get 50 grams of fiber a day or even more, that pretty much because so if you are going to get cancer, colon cancer is, so all cancers combined is cause of death number 2, and colon cancer is one of the more frequent ones. It helps with that as well. Like, there are just so many disease states that a healthy diet can support. And this is no exception, of course. Mm-hmm. So now that doesn't mean if your fiber intake is zilch right now, like if you are not really getting any fiber, don't go and eat 35 grams of fiber tomorrow and the next day and the next day. That's a recipe for disaster. So you want to just gradually increase your fiber intake.
Can you define the disaster a little bit better?
I'm not going to. I mean... Okay, fine.
Like, we're not, look, when we started this podcast, okay, let's roll this back. We help folks put this disease into remission. And sometimes people just aren't ready for the real kind of dedication that takes. And on more than one occasion, we've been accused of hoarding information. And that's not true, guys. Everything that we're putting out there, you can find on the internet. What we're doing is kind of compiling it for you and hopefully presenting it in a manner that's, kind of in line. But we are not going to pull punches. We're going to tell you very, very frankly how dire this situation is. So, Amber, when I ask you what the ramifications of going from 0 to 50 grams of diet overnight, I need to know exactly what I can expect, no matter how unpleasant that is, because what I want people to understand what happens when I do or don't do a thing, because really the cure to, or the solution to putting diabetes into remission is you're going to have to do something different. And when I do this different thing, this is what happens, right?
Yeah.
So I've given you a very specific question. You've given me a very political answer. I want to know, when I go from a low fiber diet to a high fiber diet, what are some of the foreseen and unforeseen consequences of increasing fiber in my diet, besides just helping out with the beta cell problem?
Well, if you do it gradually, the consequences are pretty positive. Mm-hmm. It's going to be more regular bowel movements and more bulk to your stool, reduced cholesterol levels, reduced blood sugar, more feelings of fullness and satiety. If you do it incorrectly and you really ramp it up, like you throw everything out in your kitchen pantry and cabinets and you're like, I'm doing this, and you eat 35 grams of fiber, maybe let's say you even cheat, which is not, and use something like Metamucil and a lot of digestible fibers.
So fiber supplement, basically.
Yeah.
Okay.
You could end up obstructed with a bowel obstruction.
Okay.
Lots of gas, bloating.
Okay.
not fun stuff.
So what it sounds to me is like the prescription for increasing fiber in my diet is very much like the prescription for increasing physical activity, whether that be walking or running or lifting or anything like that. I want to gradually, progressively increase the amount to thresholds, not jump right in there and try and lift all the weights in the gym and blow my back out. And now I'm less capable than I was prior to. In this case, we're talking about a bowel injury that can happen if I don't appropriately load the fiber into my diet. Is that fair to say?
That's fair to say.
Okay.
Yep.
All right. Okay. Sorry for the little bit of tangent there, but I really want to make sure we're giving our people actionable intelligence. So they need to know. They need to be fully prepared for what's gonna happen. Now, the $1 million question: can I regenerate beta cells?
I don't know if you can, but other people can. Yes. So, well, in type 2 diabetes, the answer is possibly, at least partially. Some studies suggest that with significant lifestyle changes, which would create improved insulin sensitivity, there can be some restoration of beta cell function, if not back to full beta cell mass.
Okay.
And there have been several remission trials. One of the most substantial would be the diabetes remission clinical trial, which is called the DIRECT trial, where intensive lifestyle interventions showed people achieving type 2 diabetes remission, and they achieved normal blood sugars without medication. More importantly, in this study, they showed restoration of this first phase insulin response, which is really the sign that the beta cell function had improved.
Okay. So let me be abundantly clear on this. There ain't a medication on the planet that will actually recover beta cell function, but lifestyle change has been shown to enable that pancreas to regenerate those cells.
Yeah, and I think if you look at a study that was put out in Diabetes Care, so this study was called the time course normalization of functional beta cell capacity in that same DIRECT trial after weight loss. So they wanted to look at like what time frame are we looking at for this potential regeneration? And what they found was that normal fasting plasma glucose was there at 7 days after a very low calorie diet.
What? One more time?
Yeah, normal fasting plasma glucose was shown at 7 days after a very low calorie diet. And usually a very low calorie diet is defined at like exactly what it says, like 700 to 1200 calories a day most of the time.
So, two things. First off, that seems pretty quick. And then second off, that also doesn't sound sustainable. Can you speak a little bit
very
to
intelligent.
that?
True on both counts.
Okay.
100% true on both counts. And although that happened at 7 days, you didn't have any kind of beta cell repletion shown at that. But you did have near normal return of that first phase insulin response at 8 weeks.
Okay.
And that was really in step with the fact that the diet had a normal amount of lipids. So the saturated fat was low, the glycemic load was not so high. Like just overall, people were not getting as many calories in as they were expending out.
Okay. So to me, this is kind of sort of sounding like, old school advice for when I'm talking to people about muscle gain. It's going to be about that 8 to 9 weeks before I start seeing that real change. That there is no, like, this isn't an overnight thing. We have to be consistent, really, really chase this remission consistently. And in about 8 weeks, I kind of started to see things kind of turning around. At least that's what it sounds like. Is that accurate?
I think that you could say that for sure. What I found interesting in looking at this is that in this particular study, they found no change in the sensitivity of the muscle cells. So no change in muscle insulin sensitivity over 2 months following remission. And then even after 6 months, only really minor improvement in that muscle insulin sensitivity after weight loss. And I believe that this is due to the fact that they were creating such a caloric deficit in this study that people were not weight training heavy. They weren't lifting and moving, because that is what's going to increase the skeletal muscle sensitivity to insulin. So kind of to summarize that, the functional beta cell capacity, which was assessed in this study, appeared to return to normal over a year.
Okay.
But in those who maintained weight loss, induced reversal of type 2 diabetes.
Okay.
So the biggest driver of all this was the weight loss. And I know, because I've seen it in my everyday experience with the people that we work with, it's not just creating a caloric deficit, it is also keeping the muscle mass at a high level over this time.
Yeah, I think this is kind of along the lines, we were talking to somebody just the other day, and they'd lost a tremendous amount of weight in a relatively short amount of time, and then almost hit like that wall of weight loss, really, really bottomed out, despite the fact that their medication hadn't changed. And it's almost entirely a function of losing lean muscle mass as fast as you're losing fat, and not having
faster.
And not having that 3 times metabolically active tissue doing the heavy lifting of, literally doing the heavy lifting. That's its job.
Right.
So
literally and figuratively, for sure.
That is any time that we're talking weight loss, and I hate weight loss. I wish it was body composition. That's so much more in line with what the goal is.
Absolutely.
Right? Like, I can't objectively look at the most elite athletes and tell how much the weight's irrelevant. It's the function that I'm looking for. So yeah, when we're talking about losing weight, at least as we're speaking about it on this podcast, Amber and I are always talking about increasing the amount of lean body tissue and decreasing the amount of adipose tissue, or layman's terms, increasing the muscle, decreasing the fat.
Absolutely. That is what you and I are talking about, but that's not all. Like, if we're talking about a specific study, if we're talking about that study in weight loss, that's not necessarily what we're talking about, because the study is just looking at weight on a scale unless specified otherwise, unless they're doing body fat assessment or DEXA scans and looking at MRI results, things like that. It's just weight on the scale. And interestingly enough, provided that the people who lost weight in the direct study, if that weight regain was minimized, so I think it was something like 16% at 6 months, and then after 2 years it was still 10%. So as long as there was a minimal amount of weight gained back, both the functional beta cell capacity and that first phase insulin response remained stable at least up to 2 years.
Okay.
So what that really tells us is that the beta cells weren't completely dead. They were really dysfunctional, stressed, inflamed, suppressed. And some recovery was possible when the vice grip was lessened, when the pressure came off.
Okay. Here's the call to action, right? If we're trying to get our folks to take action, what do they need to do? When do they need to do it? And outside of getting that fasting insulin test, is there any indication that I need to start making changes like today?
I would think if you're listening to this podcast for yourself, that's probably your sign. You probably understand or have been told that something is going on. Maybe something you can't quite put your finger on, or maybe you've been told you have pre-diabetes, or maybe you're tired after you eat, lethargic, any of those things. And it's all time sensitive. This beta cell preservation and recovery, the earlier the intervention, the more residual beta cell mass remains and the greater the potential for functional improvement. And this, in that direct trial, remission was most likely to happen within the first 6 years of diagnosis. So that was one of the criteria, that people had only had diabetes for 6 years. And it's also why even in prediabetes, action matters. So beta cell preservation, partial regeneration of the beta cells in type 2, it's not a pipe dream. It's backed by data and lots of it, not just the direct trial. That's just one of the most significant, most robust kind of trials that's out there. And it hinges, so this beta cell preservation hinges on removing the metabolic stressors that cause the dysfunction in the first place, especially insulin resistance, that glucose toxicity. So that's just high circulating blood sugar levels over time, and fat deposition, both in the pancreas, also in the liver, around your visceral organs, which is suppressing the signaling of a lot of different pathways and creating that insulin resistance. So if you have the right support, medication if needed initially, if your A1C is 8 or 9, or you really just need a leg up for a while, or if you're already on medication, don't come off of it and say, I'm going to do it, diet and exercise. Add the diet and exercise in, use the medication to help. And then as the blood sugars are controlled, have the conversation with your healthcare provider about, your doctor, your nurse practitioner, your diabetes educator, your physician assistant about coming off of these, because these beta cells can rebound functionally, and then you can, if you can get the beta cells rebounded, then you can have remission. It's within reach.
Okay. Guys and gals, please take action. Take action now. Take action, like, even if you think that there's a chance that you might have some of that early, increased insulin production, increased insulin resistance, please be proactive with this. It is so important to address this as early as soon as humanly possible to get the best outcomes. Because when that 15% function gets down to like 0% function,
your only choice is insulin.
That's it. Yeah, I'm not getting another pancreas. So again, thank you for tuning in. Please take care of yourselves. Take action early, and we will talk to you next week.
Thanks for joining us.
So here's what we know. Beta cell failure isn't sudden. It's a slow unraveling that begins long before diagnosis. But that also means there's a time to act. There's hope. Yes, type 2 diabetes involves insulin resistance, but at its core, it's about the slow, progressive exhaustion of the very cells meant to keep blood sugar in check. The good news? Those cells aren't always gone forever. With the right tools, nutrition, movement, targeted medication when needed, and consistent support, we can reduce the pressure, restore some function, and in many cases, put type 2 diabetes into remission. So if you've ever felt like your body betrayed you, I hope today's episode reframed that. Your beta cells have been fighting for you all along. The question is, what will you do to fight for them? If this episode gave you clarity or hope, share it with someone you care about. And if you're ready to take your next step towards remission, support is here. Until next time, take care of your body, your beta cells, and your future.